came about when 2 years later, where K. Raghavendra Rao, the health officer of Madras, remarked that, in quotes, "Great strides are being made in all countries for preservation of child life, and child life is truly the wealth of a nation." And so this is a third reason why they're concerned about child welfare and infant mortality rates. That children are the citizens and the wealth of a future Indian nation. The child welfare centers that were established in 1917 would employ Indian nurse midwives, health visitors, and lady doctors. And so I use the term medical women to include these three categories of women because they weren't all physicians. They had various levels of education and experience. And I also want to say that in the records of the Madras Corporation and in the speeches of people, they allied the terms nurse and midwife, although nurses were two different categories of education, but they were interchangeable. Like a midwife could have midwife training and then go for a year of nursing training. Or you could have a nurse who decided to become a midwife. And so these nurse midwives were so-called scientifically trained midwives. And we see this reference time and again. Now, lady doctors also was a diverse category. You started with lady apothecaries who had maybe 2 years of education. And then you went through terms like sub-assistant surgeons to licensed medical practitioners. And the highest level of a degree was the Bachelor's of Medicine and Surgery. This was a so-called MBBS, Bachelor of Medicine and Bachelor of Surgery. And so I want to describe the working conditions of these medical women, how they responded to challenges that they confronted, and how the Indian male members and a few female members of council evaluated these women. Now, what I'm doing here is that much of the literature on Indian medical women talks about how they faced discrimination from British male doctors and British female doctors. But what I'm saying here is that they faced a lot of discrimination from Indian male doctors that you would think would be supportive of them because Indian male doctors had faced discrimination from British male physicians. Now, the research is based, as a historian I have to say this, on two major sources that I think really provide insight into the ambitions and working conditions of these medical women. They're the proceedings of the Council of the Corporation of Madras, where they have verbatim proceedings of discussions, and some of them can be really humorous, some of them can be really something that make you angry. And the annual reports of the health officer and the lady superintendent of child welfare. These photographs that I'm showing now of the child welfare were from the reports of the lady superintendent of child welfare. Now, I should also emphasize that Madras municipal officers and Indian medical women clearly recognized that poverty was the major cause of infant mortality, but they felt unable to make any major structural changes that would alleviate this poverty. So child welfare schemes were an intermediary measure, and at times they lacked clear priorities and consistently defined clientele. For example, these child welfare centers, originally they said you had to have an income level of no more than 100 rupees a month. That was very middle class. Later it's lowered to 50 rupees, which brings it down to middle, and lower middle class. So, it's also very difficult to determine people's level of income. So that there were a lot of concern about who was getting this service. A second thing is that the Indian women who implemented these child welfare schemes faced a lot of problems. There was always a lack of financial resources. We've just been through an election, and now we're going to go through a situation where we'll have to decide what we're willing to pay for and how much we're willing to pay for it. And this was a major problem for the corporation. When the schemes are inaugurated, what do people talk about it? And as a baseline, I just want to say that in 1916, the infant mortality was 265.1 per thousand. I always wonder about these statistics. And that was the lowest ever recorded in Madras. So it was quite high if you have, 256 babies out of 1,000 born dying. They wanted to have this midwifery service, which they said would be more real help to women than the advice given to women which they couldn't implement, like because of poverty. So from the beginning, though, you get a sense of what the council thinks of child welfare. In December 1917, the council debated the hiring of a woman by the name of Miss Lucia and Veera Singh, who had obtained a MBBS, and they were going to, as a lady health visitor, give her a salary of 300 rupees a month plus 50 rupees for house allowance and 50 for conveyance. However, the acting president of the council, who was a Britisher, advised the councillor, the corporation is not committed to anything very serious. And he reduced the initial proposal for 12 midwives to 4. So we see from the very beginning that the child welfare centers are underfunded and little esteemed. The objectives of these centers were not clearly defined. Veera Singh was to check on infants whom the midwives delivered, look after them for the first year when mortality was most severe, and maintain records of them. She was also supposed to assist the midwives on particularly dangerous cases and obviate the need for these women to go to maternity hospitals. I should also point out here that when I talk about my research, many people say, well, Indian women wouldn't go to a maternity hospital because they want to be pure and they don't want to be seen by men and they don't want to be contaminated. But by the 1880s, there have been 1,500 cases a year in the maternity hospital, and that is equal to what was being done in the City of London hospital, which was serving a similar poorer clientele. So women were going. Now, the problem with doing research on hospitals is that as a historian, you go into the hospital and you ask for old records of patients. They'll say, well, we have some from 1960, I think. And you say, well, I want them from 1880. Well, there are no records, so that I don't have records of what the women who were in maternity hospitals or child welfare centers were saying about that. There was a great deal of debate among the counselors about whom these centers should be for. Because the municipal council had a mixture of Tamil and Telugu Brahmins, high-status non-Brahmins like Tamil Chettiars and Telugu Naidus, Indian Christians of various denominations, and many scheduled caste members. So one Christian, M.C. Devadas, wanted municipal midwives to service the poor and depressed classes because he said the wealthy classes could take care of themselves. A Muslim member, Abdul Qudus Bakshi, stressed that poor and Muslim women needed the services of lady doctors since they wouldn't go to hospitals because of purdah restrictions.